क्या आप जानते हैं कि नींद का संबंध हमारे पेट से कितना है? 15 मार्च को वर्ल्ड स्लीप डे के उपलक्ष्य पर अपने अपने क्षेत्र के विशेषज्ञ डॉक्टर्स और फिजिशियंस ने जब अपनी रिसर्च पेपर्स पेश किए तो साफ हो गया कि यदि पेट ठीक नहीं है या डॉक्टरों की भाषा में कहें कि किसी प्रकार का डाइजेस्टिव सिस्टम डिसऑर्डर है तो आपको ठीक से नींद नहीं आ सकती है। हिम्स के नाम से प्रख्यात हिंद इंस्टीट्यूट ऑफ मेडिकल साइंसेज सीतापुर के डिपार्टमेंट ऑफ मेडिसिन ने GERD एंड इट्स फ्यूचर ट्रीटमेंट पर्सपेक्टिव के विषय पर एक कॉन्फ्रेंस का आयोजन किया तो देश के कई जाने माने डॉक्टर्स ने इस कॉन्फ्रेंस में सम्मिलित होकर डेलीगेट्स और हिम्स के स्टूडेंट्स के सामने अपने पेपर्स पढ़े। GERD मेडिसिन के क्षेत्र की ब्रांच है जो डाइजेस्टिव सिस्टम डिसऑर्डर्स पर फोकस करती है। इस मौके पर प्रख्यात डायबिटोलॉजिस्ट एवं जनरल मेडिसिन के एक्सपर्ट और उद्यान हेल्थ केयर हॉस्पिटल के मालिक डॉक्टर मुकेश गुप्ता ने फ्यूचर एडवांसेस इन GERD एंड GI ब्लीड मैनेजमेंट पर पहला पेपर पढ़कर कॉन्फ्रेंस का शुभारंभ किया। अपने पेपर में डॉक्टर मुकेश गुप्ता ने मौजूदा दौर में तमाम क्षेत्रों में रेवोल्यूशन ला रहे AI का उपयोग GERD के क्षेत्र में कितना होने जा रहा है, इस पर बात की। डॉक्टर गुप्ता ने बताया कि हर अच्छे क्लिनिशियन को पता होना चाहिए कि आने वाले समय में आर्टिफिशियल इंटेलिजेंस बीमारी का पता लगाने में कितना बड़ा योगदान देगा। उन्होंने कहा कि बीमारी के इलाज से पहले लाइफस्टाइल में बदलाव बहुत आवश्यक होता है। खराब लाइफस्टाइल बहुत सारी बीमारियों का कारण बनता है। इस मौके पर हिम्स के चेयरपर्सन डॉक्टर AK सचान ने आध्यात्म और सही जीवन व्यतीत करने पर जोर दिया। उन्होंने कहा कि इंसानी शरीर से अधिक सोफिस्टिकेटेड कोई मशीन नहीं है और इस शरीर में केवल हार्ड मांस नहीं बल्कि स्वस्थ विचार और स्वस्थ रहन सहन बीमारी से बचाव के लिए सबसे जरूरी है। कॉन्फ्रेंस में SGPGI लखनऊ में गैस्ट्रोएंटेरोलॉजी के प्रोफेसर डॉक्टर गौरव पांडे और हिम्स सीतापुर में मेडिसिन के प्रोफेसर डॉक्टर अनुज महेश्वरी ने भी डेलीगेट्स और मेडिकल स्टूडेंट्स के सामने अपने पेपर पढ़े। प्रोग्राम का आयोजन हिम्स सीतापुर के प्रोफेसर और HOD मेडिसिन डॉक्टर निशांत कनौडिया ने किया। इस मौके पर उपस्थित डेलीगेट्स ने पेपर पढ़ रहे एक्सपर्ट से उनके विषयों पर अपने सवाल भी पूछे। देखिए वर्ल्ड स्लीप डे के उपलक्ष्य में आयोजित इस कॉन्फ्रेंस की कुछ झलकियां।
So now coming to another area, that is artificial intelligence for measuring the baseline impedance. So now this impedance phenomena can be nicely picked up by the artificial intelligence, and once again it is shown to be beneficial, it is shown to be superior. If we talk of PSPW, that is post reflux follow induced peristaltic wave, once again if we are comparing it with the best of the endoscopists here, once again the results showed the potential of PSPW to be accurately and efficiently identified by artificial intelligence. So now that puts where today we are using artificial intelligence and where it is capable of giving us an edge over whatsoever we have been doing. One is if we talk of esophagus, it is the Barrett's esophagus with pathological low-grade dysplasia. The high-grade dysplasias, they can be easily picked up by endoscopy. Then it can assist endoscopists in identifying esophageal adenocarcinoma and squamous cell carcinoma and their invasion depth. Coming to the another aspect is the prediction and effectiveness and prognosis of squamous cell carcinoma of the esophagus. If we talk of the stomach, artificial intelligence can predict Helicobacter pylori infection. It can also assist endoscopists in identifying atrophic gastritis, small intestinal metaplasia, early stomach cancer, and their invasion depth and prognosis. So these are important areas and conditions where artificial intelligence is certainly playing its role. So let us see what is the evidence. AI in Barrett's esophagus and early esophageal adenocarcinoma. Here we are comparing with best of the endoscopists trying to do his best to identify these conditions, and you can see that the sensitivity of AI is better as far as the picking up of the EAC is concerned, and it is at least not inferior as far as the Barrett's esophagus is concerned. If we talk of the esophageal squamous cell carcinoma picking up, multiple studies, don't go into the details, but just see the sensitivity and the specificity figures here. And you can see that they are hovering around 95% plus. So there, it is certainly better than the endoscopic evaluation of the esophageal squamous cell carcinoma. Another important area is HP. Even in day-to-day practice, we see that clinicians are not thinking about it. Though it is very common in our type of population that Helicobacter pylori, once you get it done, you will be surprised to see that it is present in significant proportion in patients those who are coming to us with dyspeptic symptoms. And we are not treating them. We are treating them with just PPI, which is not enough. And here, AI is capable of detecting Helicobacter pylori infection to the tune of 88% plus. So these are very important areas where we are failing as far as today is concerned, and certainly we can pick up more of these patients with more accuracy about this. And now coming to systemic review and meta-analysis, I could find one on all sorts of AI done studies. And this area is something which is very close to our chairperson Ajoy Tiwari, who has done his MSc in systemic review meta-analysis and will be presenting one in another conference. So picking up all sorts of studies and then filtering out depending upon what we really want to do is something which we do in the systemic review of a meta-analysis. And this is how we go. So we pick up all of studies and then put our question to each thing and keep eliminating the studies and finally reach to a number which is fitting in perfectly to the question what we are putting to that particular analysis. And here, out of 2,600 studies, only 19 studies they were fitting into this, and the results were here. As opposed to best of the endoscopists, the diagnosis of Barrett's esophagus is equivalently placed as far as AI is concerned, and it is superior if suppose we are talking of picking up esophageal squamous cell carcinoma. So certainly AI is something which is there to play a significant role as far as GERD is concerned. Now I will not stop before practically picking up this one slide because so very important. We treat GERD but we forget about certain aspects. But as a good clinician, you should be focusing on to the first part, the lifestyle changes that makes a big difference in treating patients with GERD. Just elevating the head end of the person's bed, whenever the person is retiring, sleeping, the bed, even if it is 15% elevated, it helps these patients significantly. Reduces the time duration of PPI.
Good morning everyone and a warm welcome to everyone from the Department of Medicine in Sataria on World Sleep Day to join us for this scientific feast on medicine, gastro and sleep. I welcome all the dignitaries, our guests of honor, chairperson, Dr. Sachan sir, Dr. Anul Maheshwari sir, all the other faculties present here. Gastroenterology is focused mainly on the digestive health and is a pivotal in understanding how digestion issues can cascade into the various health complications such as diabetes, hypertension and mental health disorders. Stress intertwined with digestive health can aggravate these issues. Similarly, poor sleep patterns often increased by digital media consumption and can further compound with metabolic problems like hypertension. So seeking medical advice is of paramount importance, but attempting self-treatment is very risky. So in this post-COVID era, gastroenterology has adapted to shifts in dietary patterns and habits, which in particularly is noticeable in the rural and urban communities both. Conditions like acid reflux, dyspepsia, bloating have become more prevalent, underscoring the importance of medical intervention. Furthermore, the prevalence of sleep disorders has surged to a great height, mainly due to the increased screen time which we all give to the various kinds of digital media and heightened stress levels. Managing these issues necessitates the expert consultation. Our department is committed to advance medical knowledge, host special clinics bi-monthly to cater individuals who may otherwise struggle to access the guidance. We give all kinds of specialty clinics on every second and fourth Friday. Whatever the accessible tea is not available in the college premises. Our dedication to research is evident in our numerous publications and presentations, both nationally and internationally. With the support of our management, faculty and esteemed figures like Dr. Anul Maheshwari sir, who is Governor, ACP India Chapter, we strive to continue our impactful work in gastroenterology, sleep, medicine, and beyond. We thank to all of those who have contributed to our endeavors, to our guests, faculty, speakers, chairpersons, and above all, students. Together we forge a path towards the improved healthcare and scientific innovation. Thank you. Now I will ask Chairman Dr. Sachan sir to have a few words and bless us.
आज स्लीप पर भी चर्चा हो रही है। स्लीप, एडिक्वेट स्लीप चाहिए। एडिक्वेट स्लीप का मतलब क्या है? मतलब है, मैंने आपको अभी 2 मिनट पहले बताया कि हम इस प्रकृति से जुड़े हुए हैं। तो एक बायोलॉजिकल क्लॉक हमारे यहाँ लगी हुई है हाइपोथैलेमस में, और वो बायोलॉजिकल क्लॉक सन से रेगुलेट होती है। तो सन का जो रेगुलेशन है उसके अनुसार यदि हम अपनी डायरेक्ट साइकिल को मेंटेन करते हैं तो हम स्वस्थ रहते हैं। हमारी स्लीप 100% लोगों की डिस्टर्ब है, बारिंग few hundred people in the whole world, बिकॉज हमारे सोने का समय है जो प्रकृति ने डिसाइड किया है वो 9:30-10 बजे है। जगने का समय 3:30-4 बजे है। क्यों है वो भी बताता हूँ आपको। लेकिन कितने लोग हैं जो इस साइकिल को फॉलो करते हैं? धर्म ग्रंथों में भी इसी तरह दिया गया, जैन में लिखा गया ऐसे करिए, लेकिन वो फॉलो भी नहीं करते हैं, सिर्फ कहते हैं। लेकिन ये सबके लिए है, वो सब जैनों का नहीं है, सबका है। पूरी ऊर्जा इस शरीर को जो ऊर्जा मिलती है वो प्राइमरी सोर्स सूर्य है। तो हमको क्यों नहीं सोना चाहिए सुबह? 4 बजे के बाद क्यों नहीं सोना चाहिए? इसलिए नहीं सोना चाहिए कि 4 बजे के बाद जो आपकी स्लीप होती है वो बीटा वेव की स्लीप होती है, उसमें नाइटमेयर्स आते हैं, डरावने सपने आते हैं। आप सबको आते होंगे जब कभी आप सोए और देखें एकदम चौंक के बैठ जाते हैं, क्या हो गया, एक्सीडेंट हो, ट्रेन का एक्सीडेंट हो, पता लगा आप लेट की नहीं है, एग्जाम हो गया, छूट गया, एग्जाम मेरा छूट गया, हम गाड़ी से ज़्यादा, गाड़ी का एक्सीडेंट हो गया। इस तरीके के डरावने सपने आते हैं उस समय और आप चौंक के बैठ जाते हैं। क्या होता है इसका मतलब ये हुआ कि आप तो बिस्तर में सीधे लेटे हुए हैं, शरीर लेटा हुआ है आपका, लेकिन मन आपका काम कर रहा है लगातार, और वो मन उत्तेजना में है, वो सिंपैथेटिक ओवरड्राइव पे है। तो वही जो दिन में हम करते हैं, पैदा करते हैं जेलसी, हेट्रेड, एंगर अपने विचारों से, वो रात में वो सपने करते हैं काम, और हम को उस समय भी सिंपैथेटिक ओवरड्राइव में रहते हैं। इसलिए उस समय उठ करके सबसे बढ़िया होता है, उस समय क्लियर माइंड होती है और आप बहुत अच्छे से उस प्रकृति से जुड़ सकते हैं, उस सुप्रीम कॉन्शियसनेस से जुड़ सकते हैं और अपने आप को, अपने विचारों को बदल सकते हैं। आपने देखा है, आप सब जानते हैं कि जब सुबह उठते हैं 4 बजे चिड़िया चहचहाने लगती है, पूरी प्रकृति जाग जाती है। सिर्फ मनुष्य को छोड़ करके ऐसी कोई जीव जंतु नहीं है जो उस डायरेक्शन को फॉलो नहीं करता, सिर्फ मनुष्य है जो भी फॉलो करता है। तो हम लोगों को इस तरीके की कार्यशाला में अपने आप को समझने की भावना रखनी चाहिए और उसको समझ करके अपने ऊपर लागू करें, जिससे कि हम स्वयं सही जीवन जी सकें और अपने मरीजों को भी बता सकें सही जीवन जी सकें। आपने रोज न्यूज़ पेपर में पढ़ा होगा, ऐसे लोग जिनकी उम्र 30 साल है, 35 साल है, उनको हार्ट अटैक हो रहे हैं, जिनके 6 पैक्स ऐप है, वो ट्रेडमिल के अंदर उनकी डेथ हो रही है। आपने कई एक्टर्स को, हीरोज को, राजू श्रीवास्तव था, एक आदर्श शुक्ला था, जो 6 पैक ऐप थे उसकी, वंडरफुल ब्यूटीफुल पर्सनालिटी उसकी थी, अभी टाइप। आज ढेरों लोग ऐसे हैं, हमारे यहाँ एक काम करते हैं डॉक्टर राजेश अरोड़ा, उनको भी ट्रेडमिल करते करते उनको हार्ट अटैक होता है। लकी थे टाइम से समय से सब व्यवस्था हो गई, जीवित है आज। लेकिन क्यों हो रहा है? तो हमको सिर्फ फिजिकल फिटनेस पे अकेले ध्यान नहीं देना है, सबसे ज़्यादा फिजिकल के साथ मेंटल फिटनेस पे ज़्यादा ध्यान देना है। इमोशनल हेल्थ उतनी ही इम्पोर्टेंट है जितनी फिजिकल हेल्थ इम्पोर्टेंट है, उतनी ही नहीं बल्कि फिजिकल हेल्थ से ज़्यादा इम्पोर्टेंट है इमोशनल हेल्थ, क्योंकि उससे ही फिजिकल हेल्थ भी मॉडरेट होती है। अभी रिसेंटली 2019 में नोबेल अवार्ड मिला है फिजियोलॉजी डिपार्टमेंट में 3 साइंटिस्ट को, और उन्होंने प्रूव किया है कि जब कैंसर सेल बनती है तो कैंसर सेल उस समय जो माइटोसिस होती है, फ्रीक्वेंट तेजी से माइटोसिस हो रही होती है, उस समय पर यदि वहाँ पर आर्टरी सप्लाई कम हो जाए तो वो कैंसर सेल प्रोलिफरेट करती है, तेजी से बढ़ने लगती है। और वो कैसे कम होती है? वो कम होती है डायबिटीज, डिस्लिपिडीमिया, एथेरोस्क्लेरोसिस। तो जहाँ जहाँ पर ये आपकी आर्टरियोल्स की नैरोइंग हो जाती है, वहाँ वहाँ कैंसर डेवलप होने की चांस बढ़ जाते हैं। आज आप देखिए, ये सिर्फ एनवायरमेंटल फैक्टर और दूसरे प्रेसिपिटेटरी फैक्टर तो है, लेकिन उससे ज़्यादा फैक्टर है हमारे इन थॉट्स का, हमारे इमोशंस का, इमोशनल हेल्थ का। उस कारण से आज आप देखिए कैंसर की संख्या कितनी ज़्यादा बढ़ गई है। हम दोष दे रहे हैं दूसरी चीज़ों को, अपने बारे में दोष ही नहीं दे रहे कि उसको पैदा मैं स्वयं कर रहा हूँ। तो इसलिए हमको ऐसे गोष्ठी में सब लोगों को ये जागरूक देनी चाहिए कि हम अपनी फिजिकल हेल्थ के साथ इमोशनल हेल्थ भी ठीक करें। आप इस वर्कशॉप के लिए, इस कार्यशाला के लिए आपको बहुत बहुत शुभकामनाएं। थैंक यू।
What is the role of beta blockers? That's what we discussed here. But we have to understand one thing, that cirrhosis can have varied presentation. It is child A, B, and C. Patient can come with absolutely normal LFT, can have jaundice, ascites, renal failure, and hepatic encephalopathy, and all of them can present with bleed. So definitely, it's not possible that beta blockers equally benefit everybody. Are the beta blockers most effective drugs, or is there a flip side to the coin also? So with that topic, we'll discuss the role of beta blockers in prophylaxis, pre-primary, primary and secondary prophylaxis, and what is the flip side of beta blockers. So I will name the topics in the following headings. Coming to the natural history of varices, as you can see, patients' cirrhosis can come with ascites, without ascites. Patients with ascites are in advanced stage of cirrhosis, so they'll have higher propensity of varices. 60 to 70% may have varices, and obviously varices can be small to large, and can have a rate of bleeding varying from 7 to 25%. And obviously each bleed is associated with high degree of morbidity and mortality. Morbidity mortality within 1 week can vary from 5 to 8%, which can go to 20% to 60%. The mortality can be because of bleed, can be because of complications due to bleed. That may happen. Once the bleed happens, blood pressure further comes down. So there is an ischemic insult to the liver that will increase the SGOT and obviously worsens the liver functions. So this is a simple cartoon that will try to help you understand how good or bad are the hemodynamics that are occurring. Normally, patients, when he is compensated, he has a normal effective blood volume. But liver acts as a dam when it becomes cirrhotic. The dam is built on portal vein. So once the blood flow from the portal vein to the liver is compromised, there is increased back pressure of the blood, leading to gut congestion, engorgement, formation of varices. This would lead to gut congestion and increase bacterial transformation of oxide, which worsens the splanchnic and also the systemic circulation, leading to vasodilatation of both splanchnic and systemic. So this would further reduce the effective arterial blood volume. So the blood volume decreases as cirrhosis progresses. So this is what constitutes the portal hypertension, and we discuss the drugs that are used in portal hypertension. So portal hypertension related complications like upper GI bleed in acute setting, it's important to manage the bleed, and the drug used at 30% it's the chronic setting in which we have to give prophylaxis to the patient. Do we need beta blockers? So chronic therapy for portal hypertension related complication, beta blockers play a role. So beta blockers can act on beta 1 and beta 2. Beta 1 reduces the cardiac output. Beta 2 causes splanchnic vasoconstriction. Cirrhosis we have vasodilatation. We require splanchnic vasoconstriction to push more blood into the circulation. Then we have alpha-1 antagonist. For example, carvedilol is a non-selective beta blocker, but it also has alpha-1 antagonistic action. This is important to reduce the intrahepatic resistance. Intrahepatic resistance, 30% is dynamic and that can be reduced by carvedilol. It also reduces the collateral vascular resistance. Overall helps improve the liver health to reduce total health. So this cartoon shows what all beta blockers can do. Can reduce the heart rate, cardiac output, decrease venous blood flow, reduce lactic acid absorption. And in the last little red circle with alpha that is basically for cardiac, it also reduces the systemic vascular resistance.
Sir, a question, a difficult situation. Patient is pregnant and she has ascites. Most likely because of cirrhosis liver or not, we cannot diagnose. So, does beta blocker help in such patients?
So, because of hormonal levels, patient will tend to accumulate fluid, but they don't develop ascites. If there is any doubt, you can always stack the ascitic fluid and do protein and albumin in that. Always, there is a glycol sac, all of you are very familiar. We take the serum albumin and ascitic fluid albumin and serum albumin, ascitic fluid albumin gradient. What the difference is more than 1.1. So yes, it is total hypertension treated ascites. So cirrhosis is causing the ascites. Once you are sure cirrhosis is causing the ascites, and on beta blockers and diuretics, patient is not mobilizing, better to stop the beta blockers. The question is, why are you giving beta blockers? We are giving beta blockers to prevent development of bleeding. That is, beta blocker does not help in any other thing. It does not reduce hepatic encephalopathy, does not reduce ascites, does not reduce kidney damage, nothing. So, if patient has heart paralysis, banding can be done. Ascites is not being mobilized, beta blocker need to stop because ascites takes away a lot of ATPs. If a patient has ascites and we tap them, all the students you tap ascites must be like it's always warm. The fluid is never cold. It may be freezing outside, but the fluid is warm. Lot of ATP energy goes on heating the fluid and maintaining the fluid at 37 degrees Celsius at least. So patient loses a lot of energy. It's a very sarcopenic effect that the patient has on ascites. That is why it's catastrophic to have ascites. Complete measures should be taken so that patient will ascites free. So if the ascites is not getting mobilized, stop beta blockers, give over diuretics, it should be mobilized.
Thank you, sir. One last comment from Department of Surgery on Dr. Gaurav's talk.
For organizing this very good gastro update, sleep gastro update. Today is the World Sleep Day. My best wishes for all people who are working for the sleep. Dr. Shweta and his team, those who are working for the sleep and their science which is related to the sleep. As Dr. Sachan has started saying with his talk, most of the time we are not really looking over the inter-speciality relationships. Inter-speciality relationships are largely being ignored and we have been confined to our specialties. The same thing is happening is when we talk about the non-alcoholic fatty liver disease. तो जब भी हम non-alcoholic fatty liver disease की बात करते हैं तो हमें क्या लगता है कि यार समथिंग कुछ ऐसा है जो कि अल्कोहलिक फैटी लिवर डिजीज में होता है, पर अगर ऐसे आदमी को भी हो गया जो कि अल्कोहल नहीं लेता तो शायद हम उसे नॉन अल्कोहलिक फैटी लिवर डिजीज कहते हैं. बट वी नेवर हैड दिस थिंग इन आवर माइंड कि दिस नॉन अल्कोहलिक फैटी लिवर डिजीज माइट बी हैविंग सम रिलेशन विद some other diseases also. There are n number of the reasons of the non-alcoholic fatty liver disease, multiple causes of the NAFLD, and out of those very important causes the metabolic reason, metabolic syndrome, obesity, diabetes, and many things which are arising out of the insulin resistance. So that's why to strengthen this inter-speciality relationship between the metabolic side or endocrinology and hepatology, this term has been now stopped to be used and is being changed to the MSLD. MSLD means metabolic associated steatotic liver disease. Steatotic liver disease means the same fatty liver disease if it is occurring in our body because of the metabolic irregularities Those metabolic irregularities may be diabetes, those metabolic irregularities may be obesity, those metabolic irregularities may be hypertension. So, by all those metabolic reasons, this healthy liver gets changed into the unhealthy one by just the deposition of the fat, what we call as steatotic liver disease. So renaming of the NAFLD as MASLD. Now what is very much important for renaming and defining this MASLD? When we were talking about the NAFLD, it was enough for us that liver is having fatty deposition, and this fatty deposition is more than 5% of its total weight. But once we are associating it with the metabolic reason, then again it is very much important that some metabolic disease must be associated with that. So, steatotic liver disease means fatty deposition, which should be more than 5% of the fat in liver, is associated with cardiometabolic risk factors. Those cardiometabolic risk factors may be related to the insulin resistance, those may be obesity, those may be hypertension, those may be dyslipidemia, all those cardiometabolic risk factors. If any of those cardiometabolic risk factors is present, we shall call it MASLD. So how this new nomenclature has been established? A total of 236 panels from 56 countries sat together. 74% of them felt that current nomenclature is not really sufficiently taking the name of its worth. The term non-alcoholic and fatty were felt to be stigmatizing by 61% and 66% of the respondents. The steatotic liver disease, or what we call it fatty liver disease, was chosen as an overarching term to encompass the various etiologies of the steatosis. So it does not really serve the purpose for the specific metabolic associated liver disease. In overall, 75% of the respondents of that external expert committee chose metabolic dysfunction associated steatotic liver disease, which was in short called as MASLD, as the replacement term for the NAFLD. I think this would be very good thing for those who are going for the examination. They may be asked these kinds of the things which are quite correct. This renaming as MASLD nomenclature were released in June 2023 by ESL conference, in which all these organizations whose logos you can see on my desktop, they are accepted and they have been in agreement of changing this nomenclature. So steatotic liver disease is a broad spectrum of the disease, and that spectrum actually encompasses from the metabolic dysfunction which is associated with the liver disease, ranging from this to encompassing liver disease which is not associated with the metabolic reason, alcoholic liver disease, and then finally there are some specific reasons for the liver disease, like some drug-induced liver disease, like monogenic disease, which may arise because of the hyperbilirubinemia, that may arise because of the inborn errors of the metabolism, Wilson's disease, and finally the cryptogenic means no cause we could establish for that kind of the steatotic liver disease. So which type of a patient will be considered as MASLD? If he is having 5% and more than that fat in his liver, with one of the 5 cardiometabolic risk factors, maybe elevated triglyceride level, maybe low HDL, having the type 2 diabetes or pre-diabetes, obesity, and high blood pressure. Out of these, anything is happening, then a person would be considered as a patient of MASLD. Now question arises, what should be the management? How should we move for the management of the MASLD, and why it is very much important to be managed? As it has been emphasized multiple times, it has been emphasized by Professor Sachan also, that now a disease is not only affecting the organ in which it is being started or it is being largely affected to that, but actually it is impacting the rest of the body organs also. The same thing happens with the MASLD also. Once we see that steatotic liver disease or fatty deposition in the liver is taking place, it is not only impacting and making the liver unhealthy, but also having an impact on the cardiovascular system. It is having an impact on the chronic kidney disease. It takes us towards the obstructive sleep apnea, what our sleep experts would be telling you more about that. Endocrine conditions, maybe multiple endocrine conditions may be associated with the obesity, hyperinsulinemia, insulin resistance would be coming up in the way. It may also become the carcinogenic and also lead to the multiple infections, and few of the outcomes may be quite specific which are reported by the patient. So NAFLD is one of the very important reasons for type 2 diabetes.
I just have to say a few things. Like in OPD, there is incidental diagnosis of fatty liver grade 1 or 2. But up till now we were like, okay, ये तो होता है. But after hearing your talk, and I think we should go for 6 monthly yearly ultrasound and advise them weight reduction, lifestyle modification, or at that point of time we should go for all the investigations to rule out the major metabolic diseases. And what is the role of serum ferritin in the diagnosis? Like just the fatty liver is not the cause of concern, and it's growth or progressive to the steatosis is mainly we should be concerned about.
कल मैं एक अपने एंडोक्राइनोलॉजिस्ट फ्रेंड के साथ बैठा हुआ था, तो एक पेशेंट आया, उसने कहा था हमारा लिवर 5% फैट है,
Fatty liver.
होता है चलता
Yes,
है.
that is.
तो ये चलता वाला जो चीज है, दिस इज वेरी मच हार्म,
Yes.
एंड दिस इज टेकिंग यू वेरी इन द बैड शेप अल्टीमेटली. So don't, first thing, always remember ultrasonography is the blunt tool for the detection of the NAFLD. Very blunt, whatever the tools are available. But of course, if nothing is there, then we should go with that. And many times हमारे तमाम सारे पेशेंट अल्ट्रासोनोग्राफी से इंसिडेंटली डिटेक्ट हो जाते हैं. हमारे पास सोनोग्राफी कराने गए, स्टोन की पेट में दर्द हो रहा है, पता चला पहले की फैमिली नहीं कराएगी. दूसरा, लेकिन कभी भी अगर आपको रियली फैटी लिवर डिजीज को डिटेक्ट करना है, तो सबसे पहले तो फिर 4 इंडेक्स देखिए आप अपना कितना है, और फिर 4 इंडेक्स में अगर आपको लगता है कि आपको यूरिक स्कैन जाने की जरूरत है, तो आप फाइब्रो स्कैन के अलावा कुछ भी और दूसरी चीजें लगाओ. And if you are finding, you can start.
Sir, deranged serum ferritin in case of normal transferrin level should raise the concern. Sir, abnormal ferritin level in when the transferrin levels are normal, should it be predictive of this?
Fatty deposition in the liver is not normal. It is not normal. 5%, less than 5% can be considered as normal. But as it touches the 5% and crosses the 5%, you should take it to be a normal. And you should try to remove it and reduce it. Less than 5%, you can continue saying that it can happen.
Okay, thank you, sir.